All right, let's go ahead and grand round started. Chuck Doan, one of our third year graduating residents, grand round today. And she picked adolescent depression as her topic. So, Chuck, let's get started.
All right, good morning, everyone. So today I'm going to be talking to you a little bit about adolescent depression and some of the things that we could start doing to improve patient care. Okay. So the objectives for this presentation, hopefully by the end of this presentation, you'll be able to recognize the prevalence of depression among adolescents in the United States. We're going to describe the diagnostic criteria of the major depressive disorder in adolescents. We'll go over some guidelines and recommendations for adolescent depression in primary care. And we're also going to discuss some appropriate screening tools for detecting major depression among adolescents. And finally, I'll go over some management strategies for adolescent depression in primary care setting. And I have nothing to disclose. However, I do want to thank you, thanks Dr. Terry Davis for her mentorship during the preparation for this presentation. So before I proceed on talking about our topic, I do want to show you a little video clip of a TED Talk given by Kevin Briel. He basically will give you a little bit of his personal experience with having depression during his adolescent years.
In 4 simple words, I suffer from depression. I suffer from depression. And for a long time, I think I was living 2 totally different lives, where one person was always afraid of the other. I was afraid that people would see me for who I really was, that I wasn't the perfect popular kid in high school everyone thought I was, that beneath my smile there was struggle, and beneath my light there was dark, and beneath my big personality just hid even bigger pain. See, some people might fear girls not liking them back. Some people might fear sharks. Some people might fear death. But for me, for a large part of my life, I feared myself. I feared my truth. I feared my honesty. I feared my vulnerability. And that fear made me feel like I was forced into a corner. Where I was forced into a corner and there was only one way out. And so I thought about that way every single day. I thought about it every single day, and if I'm being totally honest standing here, I've thought about it again since, because that's the sickness. That's the struggle, that's depression, and depression isn't chicken pox. You don't beat it once and it's gone forever. It's something you live with. It's something you live in. It's the roommate you can't kick out. It's the voice you can't ignore. It's the feelings you can't seem to escape. And the scariest part is that after a while, you become numb to it. It becomes normal for you, and what you really fear the most isn't the suffering inside of you, it's the stigma inside of others, it's the shame, it's the embarrassment, it's the disapproving look on a friend's face, it's the whispers in the hallway that you're weak, it's the comments that you're crazy. That's what keeps you from getting help. That's what makes you hold it in and hide it. It's the stigma, so you hold it in and you hide it, and you hold it in and you hide it. And even though it's keeping you in bed every day and it's making your life feel empty no matter how much you try and fill it, you hide it, because the stigma in our society around depression is very real. It's very real. And if you think that it isn't, ask yourself this. Would you rather make your next Facebook status say you're having a tough time getting out of bed because you hurt your back? Or you're having a tough time getting out of bed every morning because you're depressed? That's the stigma. Because unfortunately, we live in a world where if you break your arm, everyone runs over to sign your cast. But if you tell people you're depressed, everyone runs the other way. That's the stigma. We are so accepting of any body part breaking down other than our brains. And that's ignorance. That's pure ignorance. And that ignorance has created a world that doesn't understand depression, that doesn't understand mental health. And that's ironic to me, because depression is one of the best documented problems we have in the world, yet it was one of the least discussed. We just push it aside and put it in a corner and pretend it's not there and hope it'll fix itself. Well, it won't. It hasn't, and it's not going to, because that's wishful thinking. And wishful thinking isn't a game plan, it's procrastination, and we can't procrastinate on something this important.
So major depression in adolescent is recognized as a serious psychiatric illness with severe, extensive acute and chronic mortality and morbidity. It proves to lower education performance, leads to poor physical health, puts strains on relationship between family and friends, and patients with depression are at risk for suicide, which is the third leading cause of death in this age group. The onset of depression usually starts around between 12 to 17 years old. Of course, there are cases where patients are younger than this age group. However, it was found to be less common than adolescent age, and those that develop depression at a young age tend to have worse outcomes. So the reason I picked this topic, because as prevalent as it is, I feel like I am guilty of having really been adequately screened for the adolescent patients that I've seen in clinic. And part of it because I just feel like I didn't know what to do if I found a kid that depressed. So besides referring them. So this is the reason why I chose to do this topic, so I can educate myself and hopefully giving a little bit of what I learned, pass on what I learned to you guys. So hopefully we can do a better job at screening and identifying kids with depression and hopefully getting them the treatment that they need. So there was a survey done by the U.S. Department of Health and Human Services in 2015. And they basically asked high school students in across the United States about different depressive symptoms. And what they found was that about 30% of high school students report that they felt sad or hopeless. About 11% reported they have at least one major depressive disorder episode, meaning that the depression lasts at least 2 weeks, and that about 18% reported they seriously consider attempt suicide. 9% who reported they actually have attempted suicide, and about 3% reported that when they attempt suicide, it resulted in an injury, poisoning, or overdose that required medical attention. In another survey done by a National Health Institute of Mental Health, they also found that the prevalence of depression among adolescents in the United States is approximately 12.8%. That's 1 out of 10 adolescent kids that out there. And what also significant was that the prevalence of depression among females are significantly higher than male. So as you can see, they found out about 19% of adolescent female reported having major depressive episode compared to 6.4% in males. And the other finding that I found was interesting was that the age between 16 and 17 found to have a higher percentage of adolescents who report of having major depressive episodes. So with all those patients that report of having major depressive episode, only about 40% getting some kind of treatment. That's leaving about 60% getting no treatment at all. And within those 40%, only about 19% getting both some kind of therapy or counseling from a health professional and starting on medication. And the other 19% only get some kind of counseling or therapy through a health professionals, and only about 2% getting some kind of medication therapy alone. And so the reason I want to including this information because later on I was talking about like some kind of therapy, so I want you to kind of keep these numbers in mind toward the end of the lecture. So the challenge right now is that most pediatricians and family practitioners believe that it is their responsibility to identify depression, but few believe that it's their responsibility to treat it. Most primary care clinicians do not feel equipped or feel equipped to manage adolescent depression, and the office system are not set up to handle it. Reimbursement from insurance companies are not very incentivized. And there is a persistent shortage of mental health clinicians in the United States. Even for the areas that have both mental health clinicians available along with primary care, there's little communication or coordination going on between the two specialties. So what can we do about it? I think the first step is to recognize the problem and realizing how prevalent this problem is in our adolescent group. And then thinking about what are some ways that we can integrating some care to give care for patients with adolescent depression. So I found some steps that we can consider in taking to incorporate care for adolescents into our practice. So first, we can assess the practice. So if you are going to a private clinic or you're at a private clinic already, you want to assess your patient load. So you want to see how many patients adolescent patients are you seeing? What's the prevalence of mental health issue in your own community? And then you want to determine the role you want to play and the services you want to provide for adolescent depression. I understand that not everybody gonna leave this lecture and feel like you want to go and treat all depression, but so some of you may just want to, improve screening in your practice, or some of you may want to start considering like provide some kind of counseling or initiate medications. So whatever it is you do want to think about what kind of role you want to play. And then, of course, you want to build a network of local resources. You want to look at who are the people in the community that you can send to. So who are the psychiatrists, psychologists, or social worker that provide counseling, and what are some peer group programs that are available in the community. And then once you determine who's around, you want to establish a relationship with them, because like I mentioned earlier, it is very important to have good coordination between your practice and the referral practice. And the next step is to provide any appropriate training. So that's going from getting training for clinicians who are doing the evaluation for adolescent depression to, maybe the receptionist who will handing out the screening forms, and any kind of staff that will involve in this process. So that's also including insurance. You want to find out, is there any pre-authorization that you need to get from insurance company, or what are the billing codes that you can use to better to improve reimbursement. And then you want to assure the system in place to allow effective triage. That include a go-to list of providers and facilities to send patients as needed. So this kind of going back to when I mentioned about finding the local resources and established relationship with them. And of course, you want to understand what are the guidelines and recommendations on how to treat adolescent depression. So the key to success is that the primary care clinician must be able to see himself or herself as competent to handle this problem within a time frame of a normal visit. So I've gathered all the information that I've read and kind of put into like an action plan for primary care clinician to kind of follow, so that you can have some kind of direction on what to do to improve screening and improve identification of patient with the depression, and basically how to initiate management. So I'll go talk a little bit in detail about each one of the steps. So like I mentioned, first step is you want to identify the risk status of the patient. So the current recommendation is that any patient with depression risk factors should be identified and systemically monitored over time for development of depressive disorder, either by using a form of depression instrument or tool. So patients with the following risk factors are at risk for developing major depressive disorder. So any patient with prior depression disorder are at risk for major depression. Anyone with significant psychosocial stressors such as school failure, interpersonal family stressor, if there have been abuse or neglect, if they're in a low educational or social economic background, anyone who has parental substance abuse or in a foster care or adoption case are at risk for depression. Other factors can also include for any first-degree relatives with history of depression, history of bipolar disorder, anxiety, ADHD, or learning disability, substance abuse, patient with pessimistic coping styles, chronic illnesses such as asthma, diabetes, cystic fibrosis. Those patients with chronic illnesses also at risk for major depression. And if you see anyone with frequent somatic complaints that you cannot find organic cause, those patients should be screened for depression because they are at risk for it. So after you'd identify the risk status, you want to screen and assess for depression. So there are several guidelines and recommendations out there regarding screening, and majority of them are basically recommend to screen any adolescent who are 12 to 18 for major depression, and prefer annually. And there is an updated guidelines for adolescent depression in primary care that just recently published, I think in March, with providing guidelines for primary care clinicians on to how to manage adolescent depression. So like I mentioned, it is recommended that we screen for all patients who are 12 years or older annually for depression. And so evidence suggests that screening with systematic tool will identify more adolescents with depressive disorder than not screening at all. And screening and scoring before provider in the room is actually will be more helpful because that kind of like help streamline the workflow. So I do, at this point, I do want you to pull out your phone if you don't have already, and either text LSU Peds 477 to 2233 or go to that website. So I'm going to give you like 5 seconds to do that. Going to move to the next slide, but if you haven't done it already, it's going to be on the next slide. So on a scale from 1 to 4, please indicate your level of comfort regarding screening for depression in adolescent. So if you're using the texting, you basically just press 1, 2, 3, or 4. And if you're on the website, you basically can answer on the website. Y'all able to pull it up? Oh, okay, try again, sorry. Oh, it's a different question? All right, well, sorry. That was a glitch. So basically, I was trying to see, maybe, let's try it again, because maybe I didn't activate it just until now. Can you refresh your screen? Sorry. Does that work? Oh, okay, it's the next question. All right, so never mind. Sorry about that. Okay, so basically I was trying to get to is that, you know, screening for depression, adolescent depression, is generally uncommon despite the national recommendations. In the study by Zelia and his colleagues, or her colleague, they studied the frequency of depression screening during ambulatory office-based visit or adolescent seen in general family medicine or pediatric practices in the United States. And what they found was that depression screening is rare. And it's only about 0.2% of the practices actually screening for adolescent depression. The other thing that they found is that Hispanic adolescent was screened 80% less frequent compared to non-Hispanic white adolescents. Now, they didn't really give the reason for why, but I suspect language barrier may be one, and the fact that they may not seek care as often may contribute to this fact. And the other interesting thing was that depression screening was 9 times more likely in the Northeast compared to the West. So maybe the prevalence up there is a little bit higher. So for screening, we actually have a screening form in our EPIC that you can use for universal screening. So if you go to EPIC, once you log into their patient chart and it's under rooming, and you go to screening education and you scroll down, there's a little box that basically asks, has a 2-question survey. So you or the nurse can ask the patient whether they have little interest or pleasure in doing things, and they basically just rate on like the frequency of these episodes. And the other question that it asks is, are you feeling down, depressed, or hopeless? And of course, you click in the box that will answer the question in terms of frequency. And once the answer depends on the computer will automatically total the score. And if they're scored 4 or higher, the nurse is supposed to notify you to further screening. I'm not sure we're doing that right now in our clinic. I know Tracy does, but that's pretty much it. And I haven't had anybody notify me about our score, so we should probably start doing that a little bit more. So once the patient is screened positive, so it is recommended that the patient, that we as clinicians should evaluate for depression by interview or by using assessment tool. So basically anybody that's screened positive on the initial screening tool, or any patient present with any kind of emotional problems as chief complaint, or patient that when you see them, depression is highly suspected despite the negative screening tool. And then the other important thing is that when you evaluate a patient for depression, it is important that you talk to them or you interview them alone. So this is when you ask the patient, parents or caregiver to kind of step out of the room so that you can have a private conversation with them to ensure confidentiality. So some question that you can choose to ask during this health visit to screen or evaluate their depression is that you can start out by just asking, what do you do for fun? What do you do when you come home from school? Or do you have a best friend? Tell me about them. So these questions basically to assess their energy level or if they have any social isolation symptoms. And to assess for the school performance, you can ask, how are you doing in school? What were your grades? Is that the same, better, or worse than you have been doing? So if whatever answer they provide to you, you can assess whether they have any kind of impairment from their depressive symptoms at all that affecting their school performance. Some more questions that you could use that you can ask is that you can ask what time do you usually go to bed, what time do you get up, do you ever have trouble going to sleep, or do you have trouble waking up from sleep? And to assess the mood, you can ask about what stressed you out, what makes you sad, angry. Are you hard on yourself? Do you ever feel down or depressed? Do you ever think about hurting yourself or killing yourself? So the last question is actually very important because you always, whenever you suspect a patient with depression, you want to always assess for their suicidal ideation as part of the evaluation. So some assessment tool that you can use if you are not comfortable with asking the questions yourself, or you just don't remember all the things that you need to access. So you can use the PHQ-9 form to basically have the patient filling out, or you can ask the patient yourself, and then you can basically put out the check mark depending on the answer. And based on what they tell you, there's a scoring scale that you can use to determine whether they're depressed or the level of depression. Other standardized screening tools that you can also use to screen for depression in children are the Center for Epidemiology Studies Depression Scale for Children. This is actually recommended by the Bright Future guidelines by the AAP. There is also a Columbia Depression Scale that you can be used for aged 11 and over, and it's basically a series of questions along with the scoring system that you can use to provide more objective evaluation. And then there's also the Promise Emotional Distress Depression Pediatric Item Bank. This is actually used by the APA, the American Psychiatry Association, used by the APA, recommended by the APA to use to evaluate depression in children and adolescents. So if any one of you interested in knowing, like getting the actual form, I actually have a PDF copy of it, so I can certainly forward it to you after the grant rounds. So you can ask, like, are these screening tools really effective? So there was a study in 2015 that published in 2015 in which a group of clinicians basically did a QI project, and they basically developed a standardized protocol for screening of depression using PHQ-2 followed by PHQ-9 for any positive PHQ-2 screening clinic. And what they found was that the screening rate increased from about 10-15% to 65% in 6 months and 82% in 12 months. And the rate of referral to mental health services had also increased in the same time period. So it is effective. And if you're concerned about whether patients are receptive to this kind of screening, there was also a study done by Zuckerbrot et al., which showed that instituting universal systematic depression screening in a practice with standardized screening instrument met with little resistance by patients and parents and was well perceived and accepted by providers. Another study by Leslie and colleagues in 2018 showed that administering a patient-administered depression screening tool to adolescents during both well and sick visits will help improve identification of depression, potentially leading to early diagnosis and improve patient outcomes. So after screen and assess for depression, of course you want to diagnose the patient and rate their severity. So I do have a case that I want to show you.
Delia lives with her grandmother in the country. She's never been very confident, and when she was younger, girls used to make fun of her. She's shy. It's hard for her to talk to people. She has a couple of friends at school, but she spends most of her time alone on her computer.
Dr. Allen's office.
Yes, hello. This is Dr. Green calling from Four Corners Pediatric. I'd like to refer one of my patients to you, Delia Simmons. She's here with her grandmother because she's had bad stomach aches. She says that she's feeling tired. She refuses to go to school. She's not hanging out with other kids. And she says she's feeling sad. So there may be an emotional component in all of this. I'd like her to meet with someone. Oh, it's going to be a bit of a trip for them, so later in the afternoon might be better.
Delia, your grandmother says you haven't been going to school. Did something happen?
No.
You're not feeling well?
No, I'm sick.
How so?
Just feel bad.
Maybe I'll be able to help you.
You can't.
Talking might make you feel better.
It's embarrassing and stupid.
I'm not gonna laugh, and there's nothing you can say that will surprise me.
So there's this boy, Alex. These girls in my class, they found out I had a crush on him. Those girls, started sending me emails like it was from Alex. He liked me. It was so stupid. But I got those emails and I really thought it was from him. So I wrote him stuff about myself. Personal stuff. And then I sent an email that was really personal. And then I sent a picture of myself. And those girls sent my email to everyone in school. Everyone knew about it. I started getting emails from everyone in school saying, "Did you really think Alex would like you?" How could I have believed it?
So what are some signs and symptoms that this patient has that make you think that this patient may be depressed?
Not feeling well.
Okay, not feeling well. Not going to school. That's a red flag, right? That's it? Crying.
Look down the entire time throughout the lesson.
So not making eye contact when during conversation. Okay, so those are good. So key features of depressions can include depressed or irritable mood most of the day or every day. It can, sorry. So patient can show decreased interest or pleasure in all or most activities of most school that can lead to social isolation. They can have change in habits, so it's either they don't sleep or they sleep a lot. They show signs and symptoms of fatigue or lack of energy. So feeling tired in our case, the case that we just saw. Feeling of guilt or worthlessness. They have change in appetite every day. So it is either eating a lot or eating little. So one way you can objectively evaluate this by look at the weight curve. So are they gaining more or less than 5% of their previous weight? Change in activity, so they can present with psychomotor agitation or retardation. They can show poor concentration or indecision. So this can be reviewed through decline in school achievement or not doing well at school. And of course, anybody coming with any kind of suicidal ideation or attempt is a sign that they have major depression. So to diagnose major depressive disorder, according to the DSM-5, a patient have to have at least 5 of the 9 key features that I just mentioned to be diagnosed with major depression. And these symptoms have to be over at least present over at least 2 weeks period, and it shows a change from their prior functioning. Within 5 of those features, either at least one of number 1, which is whether they should they need to be either depressed or irritable or have decreased interest in pleasure as one of the 5 features of to be diagnosed with depression. And after you diagnose with depression, you also want to evaluate how severe is their depression, because not all depression gets the same treatment plan. So being able to assess the level of severity of the depression will help you provide an appropriate treatment plans for the patient. So for mild depression, patients typically present with about 5 to 6 symptoms that are mild in severity on the DSM-5 diagnostic criteria. They have a low score on the standardized depression scale that with a shorter duration of symptoms. And they typically can still go on with their life, so they can still maintain routine daily activities without having any significant impairment in their life. For moderate depression, these patients often experience academic difficulty. They have strained relationship with their friends or their family, and they may decrease their involvement in activities due to their symptoms. Severe depression, patients with severe depression usually show significant functional impairment in multiple domains. They also can present with symptoms with suicidal ideation attempts, plus with or without psychosis. And especially if their family and friends are really concerned about them, that's usually an indication that they have severe depression. So what do you do after you diagnose them? So the next step clinician should do is that you want to educate the family and the patient about the condition. So you want to focus on the following key points. So you want to discuss about the cause of depression and associated symptoms. So in the case in the video clips, you want to discuss about what might the trigger points or events that leading her to having these depressive symptoms. And you want to discuss about why you think that she's depressed. So you can list out the signs and symptoms that you see. And then I want to address any stigma. You want to let the patient know that it's not uncommon to have a depressive episode, and you want to let them know that with appropriate counseling and treatment, they can get better. This is not the end of the world. You also want to talk about any expected outcomes of any treatment that you propose. And the most important thing is that you always want to discuss about safety planning when you're dealing with adolescent with depression. So safety planning discussion can include remove any lethal means such as any medication or firearms from the premises. You want the patient of any disinhibiting the effects of drugs and alcohol. You want to engage anybody in the family or friends that are concerned patient about the treatment plan. And you want to develop an emergency communication should the patient deteriorate or become actively suicidal or dangerous to others. So you want to provide any contacts for crisis support hotline or names of any mental health facilities that the family can bring the patient to should one of these health crises occur. So after educating the family, you want to initiate the management. So for the rest of the step, I kind of put them all together because they kind of go hand in hand. So the goal of treatment is that to provide hopeful vision of recovering process. And you want to offer the treatment option based on their acute symptoms and their function impairment. And when developing treatment, you want to incorporate patient and families' input also. Because study shows that greater adherence to treatment and outcomes of when adolescents were assessed, studies show that the patients show greater adherence when they were assessed for readiness for change and received the treatment of choice. And part of the treatment, you also want to set any specific treatment goals. So if you want them to exercise more, you want to give them a concrete plan. So exercise 20 minutes or 30 minutes, 3 times a day. 3 times a week. And like give them any kind of, when you talk about any improving dieting, so you want to give them specific concrete food that you recommend them to eat. So maybe a vegetable like every meal or something. So they want something concrete so they can go on. So to manage mild depression, you start out with just providing active support and monitoring for 6 to 8 weeks before starting any other treatment. So for anyone with mild depression, you don't have to start prescribing them SSRI initially. You can just provide counseling and support, and you can bring them back weekly or bi-weekly to kind of monitoring their symptoms and progression. Of course, you will also want to encourage exercise and self-care behavior. After 8 or 6 weeks and you think that the patient is still not improving, this is when you want to consider starting SSRI or medication therapy. Once you initiate medication, you want to monitor them closely to monitor for any kind of adverse effects, and consider and refer them to mental health consultants. And then you want to bring them back, assess them for another 6 to 8 weeks. If by then they shows partially improvement but not completely better, you can consider increasing the medications to maximum dosage if they can tolerate it, and then continue following them for another 6 to 8 weeks. If they improve by then if they're already on medication, you want to continue the medication for at least a year after full resolution of symptoms. And of course, monitoring them frequently for progression and side effects of the medication. For moderate to severe depression, this is when you should consider consulting child adolescent psych, any therapist or psychologist available to initiate cognitive behavior therapy or interpersonal therapy. You want to continue to provide proactive co-management in your practice. And if you refer the patient to a psychologist or counseling that cannot prescribe medication, you can consider initiating a pharmacotherapy. And of course, always discuss about safety planning. So this one, let's try the poll again. Is the poll working now? Not really. Oh, there you go. Okay. Yay. So I want to see if you have anyone have prescribed SSRI to a patient with major depressive disorder within the past 6 months. All right. So 7%, 5% of you have not, and 25% if you have. Oh, yeah, I think I can access it like after I go to the profile. So to initiate antidepressant, usually it's indicated for mild depression that are not resolved with active support and monitoring, or anyone with moderate or severe depression. So statistics have shown that around 58% of primary care physicians actually prescribe SSRI, but only 8% reported appropriately, adequately trained in using them. And about 25% of pediatric primary care physicians and 42% of the family physician have recently prescribed SSRI within the past year. So that's not a really high number of people that are comfortable prescribing them. So there are several options that you can choose to if you elect to prescribe SSRI for a patient. However, I do want to note that only fluoxetine, this Prozac by brand name, has been approved by FDA for use in children and adolescents with depression, and only Lexapro, which is the escitalopram, has been approved for use at adolescent greater than 12. And any time you start SSRI, you do want to slowly monitor the signs and symptoms of adverse effect. And once you start considering discontinue it, you want to taper it slowly because of the withdrawal effect. So again, once you start in pharmacotherapy or start SSRI on a patient, you do want to monitor the symptom every 4 to 6 weeks initially to screen for side effects, and such as agitation, headache, abdominal pain, sleep disturbance, and increased risk of suicidal ideation. And this is why you have to monitor 4 to 6 weeks, because studies have shown that for increased risk of suicidal ideation is the time period where they are higher, where the risk is higher. And due to this, the FDA has issued a black box warning to be put on for all the SSRI to warn patients about this. And this is probably one of the reasons why primary care physicians are not comfortable with prescribing SSRI, because of this increased risk of suicidal ideations in children and adolescents. However, there is a study conducted by March and his or her colleagues, where they did a randomized control trial where they involved 439 volunteer patients between the age of 12 to 17 years with a diagnosis of major depression. And this study has been conducted across the United States in 13 clinics between 2000 and 2003. What I did was that they divided group in 4 groups, and basically one group getting fluoxetine alone, one group getting cognitive behavior therapy alone, one group getting both cognitive behavior therapy and fluoxetine, and one is the placebo group. And the placebo group and the fluoxetine group alone were administered double-blinded, and the cognitive behavior therapy alone and the CBT with fluoxetine were administered unblinded. And they basically measure the patient signs and symptoms of depression based on using the Children's Depression Rating Scale. And what they found was that compared to the placebo alone, or the placebo or the fluoxetine alone, the combination of fluoxetine with CBT was superior. So they have higher improvement. When comparing just fluoxetine alone to CBT alone, they found that fluoxetine is superior to CBT. And when looking at suicidal thinking, the patient in all 4 groups actually show improvement with fluoxetine group. The group with getting fluoxetine with CBT showed the greatest reduction in suicidal thinking. So the conclusion of this study is shown that the patient that getting both fluoxetine and CBT has the most favored benefits, and so the benefits outweigh the risk for increased risk of suicidal ideation. So I guess my conclusion is that, even though there is a small risk of suicidal ideation, it is still beneficial for the patient to receive an SSRI in combination with cognitive behavior therapy if they have moderate and severe depression. So for prognosis of major depressive disorder, most generally last between 4 to 9 months. So this is when you want to make sure that the patient know that they could get better. Up to 80% will have remission with treatment of SSRIs. However, if they don't get treatment, then depression may lead to adulthood if risk factors continue to present. And at least 50% of adolescents with depression will suffer from comorbidities such as anxiety disorder, disruptive behavior, and substance abuse disorder. So to review, the steps that you can take as a primary care clinician in addressing this adolescent depression. First, you can identify the risk status. You want to screen and assess their depression. You want to diagnose and you rate their severity. Then you want to educate the patient and family. And then you want to start the initial treatment, whether it's provide counseling or refer them to a mental health clinicians. And then you want to provide appropriate treatment plans along with follow-up, adequate follow-up management. So after this, if you guys want to get some training in this topic, the Rich Institute actually offering like a management fellowship for this, and it's actually just a 3-day course where they will get the specialists come and they'll provide you the skills and the lectures for you to get a little more comfortable in addressing this issue. The Child and Adolescent Psychology for Primary Care actually have educational programs that are free to primary care physicians, so they have webinars or they can even provide in-core training on site. And I did look up what are the resources that we have available in the Northwest Louisiana. So these are the places that you can refer your patient to if they have mental health illnesses, and that I put some handouts up front if you're interested. So they have the contact. So I provided contacts and number, and I did call them to verify that they actually taking Medicaid, patient with Medicaid. So a lot of these places do take them, and they are taking referrals. So in conclusion, major depressive disorder is a common health problem in adolescents, yes, yet most cases are not being detected and managed appropriately. There's the persistent shortage of mental health clinicians in the United States means that there are more emphasis placed on pediatricians to address this issue. Most cases can be screened, diagnosed, or managed in primary care setting, and that training programs and resources are available for primary care providers to be competent to handle this problem within a primary care practice. So there are some future research directions that we can be done. So if anybody interested, you can study to identify the effective methods for disseminating information and provide assistance to primary care clinicians. There need to be studies on how to evaluate methods, tools, and strategies to facilitate the adoption of these guidelines. And study also needs to be done to increase collaborative care to address the care of adolescents with mental illness. And that, I thank you. Anyone have any questions?
When they were doing the studies for the screening tests for these adolescent kids, they prefer if the kids were doing the screening tools alone without their parents watching over them, or were their parents in the room doing it? Because I don't know if some kids would want their parents to know.
Yeah, so for screening, so when you want to talk to them about depression, it is preferred that you talk to them by themselves. And during the conversation, it is recommended you want to talk about confidentiality. So this is when you ask, when you say anything they say in this room will be confidential, except for if they mention anything about harming themselves or others, and you have to break that confidentiality.
When I would, years ago, when I would see patients y'all sent to me in Pete's clinic who were depressed, and I would diagnose it alone. But then I would say, I think we need to get the help of your mom, because I think mom definitely needs to be in the picture, and often mom is no stranger to depression. Also, she needs to be aware if they're on the continuum of suicide, that they'll lock up the guns and the pills in the house. And so our mom is really, our grandmother, like in the video, really wants to help.
I think for the screening, you can screen when they're by themselves, but once you diagnose them with depression, then you want to let them know that you do want to talk about the condition with the family or the caregiver, just so that you have a, provide them more support to get over the condition.
In the surveys that showed that some primary care providers being uncomfortable or not screening, was there any breakdown in sort of age groups, thinking that people who more recently completed their training had a better understanding and maybe were more involved with the diagnosis and then management?
Oh, I don't know if I have the answer for that one.
I just wonder whether the training programs are doing a better job now than they were.
You mean
ago.
this one? I'm not sure. I can look that up for you.
Okay, just wondering whether we're doing a better job in educating people to look for this and train them on how to do it and becoming more comfortable in addressing mild depression in the office. So.
Did an excellent job.
Yeah, great presentation.
I want to say, when y'all graduate, I always ask you, or you see an adolescent, tell me what you see. And every one of them has said, look, I see a fair amount of depression. And so depression, anxiety, stress, you'll see it wherever you are.
And the screening tool can also be used, like I think, in patient too. So if you're managing a patient that have chronic, like that's getting admitted for some kind of exacerbation or like that that have chronic issues, or have recent trauma that's just very, very devastating for them, where they need to have like a leg amputated or something like that. So, and they been in the hospital for more than 2 weeks and they show signs and symptoms of depression, I think you can also start screening them in-house or using one of the assessment tools to assess the depression and get them appropriate help that they need.
All right. Well, again, great presentation. Thank you.